And this, just to be very simplistic, is a slide depicting the fact that bulk actually helps organize peristalsis. It is necessary to have bulk so that the myofibers of the intestinal tract are stretched, which in turn triggers the contraction of the more proximal and the relaxation of the more distal components of the gut to that bolus. It is easy for intestinal transit to move things along when there is bulk. It is very difficult for the gut to move things along and increase dysmotility and increase stasis when there isn't bulk. In other words, we shouldn't be expecting normal peristalsis when we are not providing adequate sources of bulk for the diet. Next slide. This leads us to the third myth. Fiber is a laxative. And that is absolutely true if you are very constipated and you have low fiber in your diet. If your diet has no fiber and you're constipated, you have a very good chance of improving intestinal transit and motility and having more regular bowel movements if you add a combination of fiber to your diet. The fact is that insoluble and soluble fiber combinations add bulk, add fluid content to colonic luminal contents, and regulate the intestinal transit. Fiber is a regulator. It is not a laxative. And we don't have time to go into extensive detail of the number of studies that show that if your peristalsis is uncoordinated and you have bulk, of course you'll improve your transit, and of course you'll improve your constipation. But the other is true too. Fiber is helpful even during diarrhea. And from that point of view, I'll just discuss one example. Next slide. This is one study of a number of studies showing that adding or supplementing fiber to children having diarrhea, and in this particular case, we're going to use an example such as antibiotic-associated diarrhea. The number of loose stools and the duration of the occurrence of loose stools during antibiotic treatment can actually be decreased by adding a combination of soluble and insoluble fiber to the diet. And this goes back to the chemical and physical-chemical properties of fiber. What we want is functionality from the point of view of enteral feedings or diets that come in liquid. In this case, in children having loose stools from any type of problem. This is true and has been shown, for example, similarly for rotavirus diarrhea. Diets that increase the amount of fiber during diarrhea help transit, decrease loose stools. Diets for patients who are constipated help transit and increase the frequency of stools. Next slide. In summary, the insoluble fiber in the diet in particular helps regulate stool consistency because of its water-holding capacity. It softens the hard stool, and it improves the consistency of loose stools. It facilitates the motility of the gut. It gives the gut something to work, and in that way helps regulate intestinal transit. Next slide. The other myth that we also have kind of lived with is that if you got a diseased gut, particularly if you have an inflamed gut, fiber may actually be or could be contraindicated. And this goes back to the use of the so-called elemental diets for many of these patients that may benefit from, yes, the nitrogen delivery that we can provide with different types of protein hydrolysates or amino acids. But the fact is that not providing fiber is not feeding the gut. Fiber helps maintain gut function and integrity. The problem is that this myth has continued to persist. Most hospitals do have these so-called low fiber, and worse even, these so-called low residue diets. Next slide. What are the indications for low fiber or low residue diets? And in a recent search, and you can go reach high and low and do all the research for this, there's not a single reference that you will find that supports the use of so-called low residue diets outside the use of sunflower seeds in patients with Crohn's strictures, of course, that supports the fact that these low-residue diets are going to help intestinal function. And I'm just putting here an example of the fact that this continues to be in the textbook. This comes from Cohn's Current Therapy just from last year. Total parenteral nutrition should be used in malnourished patients who do not improve quickly or are unable to tolerate oral intake. As symptoms improve, I'm not sure what symptoms, because for the most part TPN is not going to help their GI symptoms, patients can be transitioned from TPN to a low-residue diet. And you'll find statements like this in many textbooks. What you will not find is a reference. Next slide. Most interesting thing, this actually permeates far beyond the medical community, and of course now we all go to the trusty Wikipedia sources that talk about low-residue diets and how important a low-residue diet is, because it is designed to reduce the frequency and volume of stools while prolonging intestinal transit time. I think the last thing we want to do with a patient that is sick is to prolong their intestinal transit time, increase stasis, cause dysmotility, and in no way are we helping their loose stools if they have it. In no way are we helping their constipation if that's why they have it. Next slide. Let's switch gears just briefly to the fact that fiber also is critical, not in supporting motility, not in supporting the physical-chemical qualities of the bolus of food that persists in the intestinal lumen, or what the colonic softness or hardness of the stool is, which is critical in terms of the insoluble fiber composition of diets. But fiber also supports the intestinal flora, or to use the modern term, the intestinal microbiota. We need bacteria for many reasons, and we'll briefly discuss these. And these bacteria that inhabit the lumen of the intestine, which is not inside us, the lumen of the intestine is outside us, is populated by a number of bacteria that have a number of functions. And this is a very complex ecosystem. This ecosystem, which is necessary for adequate gastrointestinal function, is very complicated. As many people quote, we have probably 700 to 800 culturable species of bacteria in the GI tract. There's probably more that we haven't even cultured yet. There are different types and different amounts of bacteria in different areas of the GI tract. As you all know, the intestinal microbiota is different in the proximal GI tract than it is in the distal GI tract. Nevertheless, it is critical for adequate GI function to have a balanced intestinal flora, and important for a number of reasons. Next slide. An intestinal microbiota is important because the variety of species is necessary so that one species competes with another, so that we don't have the predominance of one single species which potentially could be deleterious. If there is no competition in this ecosystem, we have increased chances of a pathogen growing as a primary bacterium, and we have increased chances of pathogenicity. We know fermentation is absolutely critical. We know the production of short-chain fatty acids is important for gut structure and function, particularly in the distal gut. We know that the flora is necessary for adequate metabolism of bile acids and enterohepatic circulation. We know that it is important for the synthesis of vitamins, for example. And more importantly, and most recently, we know that maintaining an adequate microflora is absolutely necessary for adequate gut function, particularly in the young pediatric patient. Next slide. But bacteria need food to live. The food for maintaining a healthy intestinal flora, of course, is fiber, which is the unabsorbable part of the diet. These bacteria utilize substrate, and we're not going to go into the many ways and many metabolites, both potentially positive and potentially negative, that bacteria produce. But let's just briefly talk about short-chain fatty acids, which I'm sure most of you are familiar with, and this includes acetate, propionate, butyrate, all these short-chain fatty acids, which are critical for GI function. Next slide.